think back on lecture or sermons that the minister that I particularly like to listen to, I remember a particular kind of statement that he often initiates his discussion with, and he often says that his job is to comfort the afflicted, but also to afflict the comfortable. And so that's what I'm going to try to do today. I'm going to try to afflict the comfortable. And what I wanted to point out is just how remarkable it is that we've become comfortable. So I want you to picture my interview with a patient with follicular lymphoma. I'm now coming to talk with them. I have all of their staging testing done. I know everything about what's going on. And they are completely asymptomatic. And so I walk in and I say, "Hi, I'm Dr. Connors. I'm an expert in lymphoma. You really should listen to what I have to say to you. You have widespread disease. You have a cancer in much of your body, afflicting organs outside of the lymphoid system. It's all over the place. You have a disease that people die from. This is not a trivial or a minimal sort of disease. Folks actually die from the kind of disease that you have. If I don't do anything," you're asymptomatic now, "if I don't do anything at all, within 2.5 years, you've got a 50-50 chance of actually being sick from this disease. Not just having it come back, but actually being sick from this disease. And sitting over there on the shelf in my pharmacy, I have some really slick treatments that work excellently with 90% response rates, excellent control of disease. And so in our wisdom, we have decided for your disease, we're not going to do anything." Now, it's absolutely remarkable that we are comfortable with that particular idea. So let's see if I've got the right projector thing here. It must be the wrong one. My disclosures, and so I receive research funding from various not-for-profit and for-profit entities, and serve on the advisory board or otherwise advisory committees of several for-profit and not-for-profit organizations. And I'm going to talk about now some basic principles and observations that I would need your agreement to conclude my argument. So first of all, our chemotherapy intervention for symptomatic progression of follicular lymphoma improves survival, not progression-free, not relapse-free, not disease-specific. It improves overall survival. Why do I say that? Well, before I even start, I have to say what constitutes symptomatic disease. And I've put up the list. You can glance through the list, but I don't think you'll find that this differs very much from your regular practice. That is, when people have these kinds of problems from their follicular lymphoma, you think it's appropriate to initiate some kind of treatment. And we have helpful studies. You're all familiar with them, so I can go through them quickly. This is often referred to as the Marcus study, CVP versus CVPR. And the important thing here is to go to the bottom, the update of the outcome for this trial. And there is an overall survival benefit for the patients that were provided with chemoimmunotherapy, chemotherapy plus rituximab. I emphasize that because remember that overall survivals are often heavily influenced by secondary treatments. But what this tells you is that if you didn't get rituximab as part of your primary therapy, you can't catch up. Your clinician can't catch up with that by doing other things later and equalize the overall survival. You've forfeited the potential benefit, and that the chance of staying alive is now reduced because you didn't get the rituximab up front. So that's why I say that it's important to emphasize overall survival, and why I asserted that this is necessary to be part of your primary therapy. So do we have other data to support this? Well, we have data from the comparison conducted by the Germans. I focused on the older patients because it turned out that the 2 different doses of interferon didn't make any difference. So we can go back and think what happened with the primary randomization. That's now CHOP versus CHOP plus rituximab. And here, if we go to the bottom line again, there's a reduction in overall survival, or the likelihood of dying from the disease. So once again, we see the same effect. And look at the hazard rate there. The reduction is not trivial. It's substantial. It's more than a 50% reduction in the risk of dying from the disease. Once again, if you don't get the treatment up front, it can't be made up for by later maneuvers. Okay? And another recipe, FCM versus FCM plus R, and if you look at the curve on the right-hand side of the slide, you can see that there is a survival benefit here. So I think that case can be made. How about the case of if you have R chemotherapy and then get R maintenance therapy, does this improve survival? And it's very helpful that Dr. Sals already gave his lecture because I think he's made my case for me, but I'll run through some of the data. Let's back up. ECOG tackled this question by giving plain chemotherapy and then randomizing people to R maintenance versus observation and demonstrated a survival benefit. But of course you'll say, well, they didn't get the R up front, so we have to look further into our data. Well, we do have the look at what happens to patients with relapsed follicular lymphoma. And I want to emphasize one aspect of this study that doesn't come out very often, but the patients that went on to this trial had been very minimally pretreated. A third of them or a quarter of them had had only chlorambucil. Another large group had only had CVP, and then they relapsed, and then they were randomized to CHOP versus CHOP plus rituximab. And we know that in that comparison, the rituximab-containing arm won out. But there was a second randomization, and that had to do with observation versus maintenance rituximab. And once again, you know that the outcomes have been well publicized. The R maintenance conferred a survival benefit here. Again, having gotten it, you did better and you stayed alive despite what your physicians might do later on to try to catch up if you hadn't had the R maintenance. And this turned out to be true, if you like, both in the group that had primary CHOP, no rituximab, but also in the group that had CHOP plus rituximab. And so we have the PRIMA study, and much is sometimes made of the fact that there's not any difference, lower right-hand side there, that the survival curves, they haven't separated. But how could they possibly have separated at this point? The two curves are traveling at the 90% mark. And if it ever emerges from this trial, it'll be well past the 5 to 10 year mark that we start to see them diverge. And so we'll go to that meta-analysis that you also heard from Dr. Saul, focused on the bottom. And there is some apples and oranges here. There's a variety of different kinds of treatments followed by maintenance versus observation. But at least the triangle lies, or the diamond lies to the left of the mark. And in this meta-analysis asserts that in getting maintenance rituximab leads to an overall survival benefit. All right, does this make any difference? Yeah, this is what has happened in British Columbia. These are just era over era comparison, telling you about everybody, fairly large numbers there, of follicular lymphoma in our province. And in those 3 eras, we've seen a 33% reduction in the mortality from follicular lymphoma. So putting all this rituximab into the mix does seem to have translated into a genuine benefit. A third assertion that I want you to keep in mind as I go through the data from the trial we'll discuss, the rate of progression of patients followed after an intervention or even after a lack of an intervention, but then just followed, always decelerates with time. So what do I mean by that? Well, let's look at the curve from an older study of observation versus intervention. This is the Ardeshna study previously looking at chlorambucil now or later type of thing. But notice that on the observation arm that the curve decelerates. At the beginning, the progression rate is 20% per year. At the end of the follow-up, which is very long, it's all the way down to 2% per year. Well, there's nothing magical going on here. In fact, this is exactly what you would expect. If we think about who these people are, some patients initiated their observation with a high tumor burden and a relatively more rapidly proliferating tumor. If you have both of those characteristics, then the relapse rate per year is going to be fairly fast. Some of the patients only had one of those two. Either they had a high tumor burden and a low proliferative rate, or a somewhat faster proliferative rate and a low tumor burden, and they're in the middle, the second phase of the curve. And then finally, there are the people that started the observation with a low tumor burden and slow proliferation. Of course, they're the ones that have the slowest progression. They're way out on the tail end of the curve. Is this a general principle? Well, let's just look at a bunch of trials. Here's the SAC trial, prolonged versus short course rituximab. In both cases, the curves decelerate with time. Here are some biomarker studies. These are just slides I borrowed from Randy because they were handy. So impact of lymphoma-associated macrophages. But the point now is not the biomarker, it's the fact that both curves, even the bad curve, decelerates with time. A different marker, FOXP3, looking for T regulatory cells, decelerates with time. So those are the three background concepts I want you to carry in your mind as we talk about a trial that I've found extremely provocative and very useful to think through the full implications of the trial. And I'll remind you that on the one hand, it's always important to say, what did we learn very specifically in this particular trial, for any trial that we look at? But it's also necessary to think, how should this alter our concept? What does this tell us about what we think we know about this disease and its response to treatment? And projecting beyond what this trial actually showed, what do we think is the most likely thing to be the longer-term outcome, and how should that influence our practice today? So let's march through this. I better leave that up for a moment, hadn't I? The comparison here is to take asymptomatic patients, no threatening disease with their follicular lymphoma, and assign them to one of three arms in a randomized fashion, standard old watchful waiting, 4 doses of rituximab, brief course of rituximab, versus the same 4 doses of rituximab and a Q2 monthly, 2 years worth of maintenance rituximab. So we've got 3 different groups to look at here. The endpoints, the endpoint of particular interest is time to next treatment. I like that endpoint. These patients don't so much care about an asymptomatic progression later on, which doesn't require intervention. What they care about is, when are they going to have to take that awful stuff that we hand out again? That is, the treatments that we typically give to patients for relapsed disease. So the endpoint was, when did you have to initiate another treatment beyond the watchful waiting or the 2 different rituximab assignments? And secondary endpoints are being gathered, and we'll focus on a couple of them, but remember that time to initiation of treatment. What did they say were the general rules under which the intervention should be offered? Very close to what most of us would use in practice. Symptomatic disease, quite threatening disease, interference with organ function disease, all of the things that most of us would feel comfortable at saying, this is the time we ought to get started with treatment. Who did they wind up putting on the trial? Do these people resemble our own watchful waiting population? Well, that's a busy slide, but I'm going to focus your attention on just 3 aspects. These were very highly functional patients with excellent performance status, and as you can see there, no compromise of their performance status from the disease in the large majority of cases. They did have disseminated disease, so this is advanced stage follicular lymphoma. They did have very infrequent elevation of their LDH, another marker for a potential aggressiveness of the disease. So I think they got it right. They put the right people onto watchful waiting. They didn't see a lot of toxicity, so this was reassuring. We didn't expect to see a lot. We wouldn't expect watchful waiting to cause a lot of toxicity, nor did either of the 2 rituximab arms cause very much. But there was an asymmetry between the arms that I don't have on a slide, but the patients that had more treatments had more adverse events. That's no surprise. So the 4 doses versus 4 doses followed by maintenance, there was a higher encounter of adverse outcomes in the patients that received the many doses of rituximab, but nothing emerged as particularly surprising or worrisome here. And when they looked at a kind of a landmark analysis, where did the patients stand after just over 2 years? So this is 2 years from when the people that got the 4 doses of rituximab finished their treatment entirely. What had been accomplished? What had happened to the disease? And you can see that nothing unexpected emerged here. A very small number of the watchful waiting patients had regression of their disease. That's in keeping with the occasional spontaneous regression of the disease that we see. A little bit of rituximab and a moderate response rate, a lot of rituximab and a higher response rate. So no surprise emerged here, and rather what we would have expected in advance is what occurred. And the overall survival of these people is excellent. In fact, it's surprisingly excellent. So it's way up at the 90% mark, even as we get out to the 5-year mark. keep that in mind, because if we go back and look at the previous study of watchful waiting versus something, things didn't turn out like that at all. And there, the 5-year overall survival of both arms, including the watchful waiting arm and the intervention arm, is only 60%. So look how big a difference that is. We watched them back then, this is 80s into the 90s, and 40% of them die within 5 years. We do the same thing, we watch them today, and 90% of them stay alive. So there's a very limited capacity for us to use this older study to talk about what happened with the newer study. Now, I wanted to point that out. And this is also not surprising, sort of, if I look at our overall era-to-era type of comparison, that 5-year survival mark is up towards the 75% mark. Notice that that's a group that starts in 98 and probably hasn't yet reflected the full benefit of adding rituximab and immunotherapy to their management, but it is well above the 60% mark seen in that older study. So here we go to the key aspect of this particular study, and that's this business of time to initiation of new therapy. So did anything surprising happen here? Well, the time to initiation of new therapy for the people that were on watchful waiting was 2.5 years. We can go back then and say, is that different from what we usually see? Well, that's our experience with 270 patients plus, managed with watchful waiting that looked very similar to the ones on this trial. Our time to initiation of treatment, 3.1 years, I don't think remarkably different from that 2.5 years that they saw on the trial. So I think the trial is telling me about patients that I can generalize to our population in BC. And also note that by the time you get out there to 5 years, 3/4 of patients have actually required an intervention. Now that's what happens in our province. If we go back and look at that older study from Ardeshna, 50% of the patients are on treatment within 2.6 years, and 75% are on by 5 years. So by the time you get to 5 years, pretty good chance you're going to have taken treatment. Watchful waiting doesn't last forever. Back to time to initiation of new therapy for the study in question. Well, there's the time to initiation of treatment. But let's look at these two intervention arms. First of all, they traveled together. They're not statistically significantly distinguishable. And they're traveling at about the 80% mark out there at the 5-year follow-up period of time. I'm going to now shift things over and predict the future. That's, of course, obviously always dangerous. But we can, I think, at least conduct a useful thought experiment. So let's take those two patients, or those two groups of patients who had the rituximab, and think about the worst case that might happen, and that is that once we get past the 5-year mark, and remember now that that is 4 years and 11 months after the patients had rituximab, if they were on just the 4 doses arm, what might happen to that curve? Well, maybe it'll accelerate. That is, having had only a 4% per year relapse rate, it will suddenly jump up to a much faster rate, a worst case scenario. And when will it encounter the median time to initiating of treatment? That'll be at 6.5 years. But I tried to construct the argument earlier that that would be extraordinary in the sense that nobody else or no other experience shows us some kind of acceleration at this period of follow-up, but in fact, you tend to see a deceleration. So let's have an intermediate case here. Maybe the rate won't change. Maybe it'll just continue to be 4% per year, as it has been during the first 5 years of follow-up. Well, it will encounter the median time to initiating treatment for those patients who had an initial intervention at somewhere around 10 years. Or even more likely, the most likely case, that is that we will see the usual deceleration of time to relapse. As we follow that curve out, it's out past the 12-year mark. So yes, this is a thought experiment, but we do have to think for our patients that we're managing today, what's most likely to happen from the data that we have already in our hands. And at least I think you can make a reasonable case that the most likely thing is that we'll see over again what we've seen so many times in the past, a deceleration of time to needing initiation of treatment, and it will really be out there past the 12-year mark. Well, what are the implications of that? Well, let's take the most likely case and walk through kind of scenarios of what will have happened if you think about a provincial management approach to taking care of these patients. We're out now at the time to initiation of treatment of past 12 years. Well, that means that we're going to have to intervene for these people. I already tried to construct the argument that once we do intervene, it ought to be with chemoimmunotherapy plus maintenance rituximab, because that improves survival. And if you don't get that when you're symptomatic and you need your treatment, you'll never be able to make up for it by later treatments, at least with the techniques that we have available today. So they ought to have then intervention in BC, CVPR plus maintenance rituximab. You could do the same kind of calculations with CHOP plus rituximab and they wouldn't look any different. So let's think that through in terms of cost. Well, there's our most likely time to initiating treatment. And let's do the numbers on this. Well, during years 1 to 12, let's suppose we chose the red line. We're going to give these people 4 doses of rituximab, and we're going to give it to everybody. Well, in BC, we encounter about 25 patients like this per year. That is, 25 people with follicular lymphoma that we put on watchful waiting as our purposeful way of managing their disease. Well, if I'm going to now intervene, I'm going to have to give every one of them a full course of 4 doses of rituximab. That costs us somewhere around $12,000. So we're going to have to invest $3.5 million over the next 12 years to get every one of these patients onto rituximab. During that time, there will be 150 of them, the median time to needing an intervention. There will be 150 of them that also required treatment with CVPR plus maintenance rituximab, which costs about $50,000. So I will not only have to have spent the money on the initial chemotherapy, but I'll have had to spend the money on the half of the patients that required an intervention. But of course, half of the patients didn't require an intervention. And those half of the patients who've gotten all the way to 12 years without needing an intervention, I have yet to spend the $50,000. And so, if you like, I will have saved $38,000 on each one of them, at least through the 12 years of time that have gone by. And then you can just do the net savings calculation, but this comes out to about $3.6 million saved by the province of British Columbia if we decided to do this tomorrow and if things work out according to a most likely scenario. Well, we could have assumed that the worst case occurred. Somehow or other, mysteriously, differently from anything we've experienced in the past, the time to initiation of treatment curve accelerates past that 5-year mark. It encounters the median at 6.5 years. And I can do the same kind of calculation, and when I do that, I still save money. That is, if you do the numbers, simply looking at the fact that you will still only have to have treated half of the people at 6.5 years, you're still going to save over $2 million over the run of that time. So you can see where I've gone with this, with our most likely scenario out there to 12 years. With those kinds of savings, in BC, we're going to save $300,000 per year for our desperately besieged oncologic drug budget, which is under siege as most of our provincial budgets are. Here's an opportunity to step in with an intervention that demonstrably leads to a clear-cut savings over time. So I think that the time has come for us to move away from something that, as I said, we've become remarkably comfortable with, that is not intervening despite systemic disease, ability to monitor and alter the course of the disease, disease that's going to make people sick within 2.5 years if we don't intervene, all of those characteristics. And I think that the era of watchful waiting should actually be considered over. And until better guidance appears, we might as well choose the cheapest but still apparently effective intervention of just 4 doses of rituximab. Of course, that arm with all of the maintenance might actually be stronger, and those data will emerge over the next 5 to 10 years. We can always change later, but for the moment, the thing that would make the most sense in terms of cost and reducing toxicity for these patients will be to offer them the 4 doses of rituximab. The savings will be that every time you encounter another patient you might put on watchful waiting, you can anticipate saving $12,000 per patient per year as these people roll into your program. So you can do the math by, I put that number in just in case you want to do the multiplication. If you see 100 patients in your province that are suitable for watchful waiting, it's 100 times that savings that you'll see per patient. And finally, I haven't actually concentrated on a different aspect, but I want to close by emphasizing, and that's clinical benefit. So if you think about this way of approaching disease, at least 40% of the patients will avoid the necessity to intervene for at least 10 years. What does that do for a patient? Well, many patients will actually outlive their lymphoma. We encounter this kind of a scenario in patients that are in their 60s and 70s and often have comorbidity. They'll never need an intervention during the rest of the course, having had that one single intervention with the rituximab. Many more patients will live long enough to receive new, better, potentially curative treatment. We've gotten much better at treating follicular lymphoma in the last 10 years. There's no reason not to expect us to get better at managing it in the next 10 years, and maybe we will find potentially curative treatment, or at least less toxic treatment, and patients will have had the opportunity to not have to be subjected to the toxicity and inconvenience of treatment until we have a better way of managing them. So I think that as comfortable as we've grown to be with watchful waiting for the past 40 years of experience, and that's when it was initially described 40 years ago, the time has come to make a change. Thank you very much.